share the screen later. share my screen anytime.
Good morning, everybody. Welcome to Mindray webinar about critical care ultrasonography. Today, I would like to introduce Dr. Ashraf Al-Tayyar, Consultant Head of ICU and Respiratory Therapy Department in the Security Force Hospital, Course Director of Critical Care Ultrasonography, Eastern Province, Director of ICU Club in Eastern Region, Council member of Middle East, representative at European Society of Intensive Care, WIN Focus faculty, American Society of Critical Care Medicine, Critical Care Ultrasonography course faculty, Chairman of CPR RRT Trauma Committee of Security Force Hospital in Dammam. Please, during the presentation, if you have any question, please feel free to write it in the chat box. Thank you. And now let's welcome Dr. Ashraf again.
Thank you very much, Mr. Muhammad. It's my pleasure to be with you tonight, and thank you for Mindray Company for hosting this very important webinar. And thank you, very special thank to all attendees tonight. Without any further delay, I'm gonna try tonight to convince those who are not yet convinced or slightly convinced of the importance of having critical care in general, critical care ultrasonography in your acute care setting. And what we need by acute care setting is not only ICU, but emergency room, OR, acute medicine wards. If in some hospital, they have units in medicine or in surgery. So, as you know, when it comes to ultrasonography machine, it's a very simple to use, bedside, portable, no radiation exposure, no risk on patients or the staff. And also, it's a very, very easy to learn and very simple to use bedside. So these are the advantages when it comes in comparison to other modalities in radiology in critically ill or acutely ill patients. The other modalities like chest X-ray or CT has a lot of risk on patients, not only radiation, which we are underestimating the risk of radiation by thinking that the radiation exposure is minimal. Yes, it's a minimal. The diagnostic radiation exposure is minimal. But imagine you're doing daily chest X-ray for your patient who stays in ICU for a couple of days, if not weeks. So how much risk he or she as a patient and your staff is going to expose to the radiation in daily practice. And also, you have to move patients who are not sometimes stable to be moved outside of ICU to do sort of X-ray or radiology investigation like CT or MRI. While what you want to answer as a question can be answered by very simple test, bedside modality, ultrasonographic modality, and the majority of indications are easy to learn. I'm insisting for this. So, and also, it's not only that you request CT or chest X-ray to be done, how long it takes sometimes to negotiate with people to do CT or to ask somebody to bring the portable X-ray machine, a technician will come. to answer for you a simple question again that can be answered by few minutes ultrasonographic exam. By ultrasound, you can diagnose a lot of life-threatening conditions in no time. And you can, based on this diagnosis, to plan your interventions that can be sometimes life-saving. Cardiogenic or non-cardiogenic pulmonary edema, shock, what type of shock and what sort of intervention I have to do for this shock patient. Does all patients who seem to you that they are in septic shock are septic shock? On the other hand, are there all cardiogenic shock patients? Are only cardiogenic shock? Or the most common shock, as we know from evidence, is combined type of shock. And without diagnostic modalities, you wouldn't be able to diagnose the type of shock. And as everybody is saying, in a hemodynamically unstable patients, you have to see the morphology and function of the heart before you decide why this patient is shocked and what he or she needs to treat his shock status. Many indications, life-threatening indications, or diseases or abnormalities that can be easily diagnosed by bedside examination by ultrasound, pulmonary embolism, pneumothorax, effusion, pneumonia, many other things, DVT. And that's why people nowadays started since a couple of years actually to talk about that the critical care ultrasonographic machine has to be maybe alternative, not only to radiologic other alternatives, but also as a supportive, if not alternative, to physical examination. Inspection, palpation, percussion, and auscultations are the four pillars for physical examination. Critical care ultrasonography is added in acutely ill patients as a fifth modality or a fifth pillar for investigating why this patient is diseased. The importance of that comes more and more emphasized in the era of, or the dilemma or the crisis of COVID-19, when you want to try to minimize the direct contact with your patients physically as much as you can. So instead of putting the stethoscope or doing percussion to see if there is a dullness on the basis of the lung, and this might be collapse, might be fusion, you can just put the probe while you're maintaining some physical barriers, and you see everything with your eyes without putting differential diagnosis. Effusion is going to be very obvious. Consolidation is going to be very obvious. Pulmonary edema, typically for cardiogenic, it doesn't take much. And as I'm insisting to mention that this is easy, guys, to learn. So there is no excuse for us working in ICU or acute setting not to learn the basic of critical care ultrasonography. There is a lot of evidence, and this evidence is showing not only that the ordinary machines that we are using are effective, but also the hand-sized maids, new machines, was found by evidence, by good body of literature support, that it is, although with limitations of these machines' capabilities, but it was found to be far away better than if you rely on your physical examination, even if you are expert. If you look at this one, you're going to see that in this study, 82% was the accuracy of handheld ultrasonographic machine, the small machines, in comparison to 47% accuracy only if senior people relied on physical examination to detect common pathologies on the heart and lung. Look at this study. It was a very nice study. First year medical student, after 18 hours of training and education of how to use ultrasound, after 18 hours for the first year student, they were more accurate than a board certified cardiologist to pick up finding on echo. Their accuracy was 75% compared to 49% when the board certified relied on physical examination. So the machine added to the accuracy of diagnosis. There's no doubt of that. And that's why we started since a long time. And there is more emphasis on that we have to rely on critical care ultrasonographic point of care machines in our units to diagnose our patients and to manage them and to follow them up. And that's why it's not surprising for me to see among the recommendation of big societies that teaching this in pre and postgraduate is a must in the medical curriculum. And the hospital setting has to, as recommended by many, has to prepare itself, these hospital settings, to have in every unit of acute care units a bedside point of care ultrasonographic machine. If you look at the big societies of critical care medicine worldwide, you're going to see more and more emphasis on the importance of critical care ultrasonography. This was recently published from both American Society of Critical Care and European Society of Intensive Care Medicine. And what they said as a standard of care, the standard of care necessitate that every patient in ICU or in acute setting, if they are hemodynamically unstable or with respiratory failure, they have to have a whole body holistic ultrasonographic exam of both heart and lung, not only that, but also screening the abdomen and venous system, because you have to have immediate, and not only immediate, but also serial evaluation by ultrasound for hemodynamic status of your patients. What they necessitate on that the thoracic ultrasonography can be a replacement for the ordinary chest X-ray and also CT chest. This is the recommendations nowadays, that every patient with respiratory failure and cardiovascular failure should have critical care ultrasonographic examination. What I'm very, very interested to see, I'm very eager that everybody has to know that it's not limited to the basic knowledge of critical care ultrasonography. People now is fastening and enhancing the culture of critical care ultrasonography to include what we believed before, that it's not at all for critical care environment. I'm talking particularly about transesophageal echo in acute illnesses in critical care setting. There is a big emphasis since long time now. If you go to the literature, you're going to see that the interest in critical care ultrasonography is increasing dramatically since it was just given as a notion on 1985 by a physician working in ICU. In 1985, when he started to think that echo can have a role in critical care management, especially hemodynamically unstable patients. Gush of literature was following this idea, and you can see here from this slide how big 2015, and I'm sure 2020, it becomes more and more bigger compared to 1995 or 1997 or the beginning of 2000. There is a dramatic increase in only one decade. The interest increased very significantly. And that's why, again and again, the big societies, if you go to their recommendations, you're going to see in developing world and in well-resourced or developed countries, they have to share the same responsibility that every intensivist has to be competent in critical care ultrasonography. Every ICU resident and fellow has to receive a standardized training. Listen to this statement very clearly. And I know that among my respected attendees today, there are program directors and there are people who are senior in their units. It's not luxurious and not optional. They have to, the resident and fellows, they have to know a standard of critical care ultrasonography exams. And I'm afraid to say that in some sects of the critical care ultrasonography in general, it's medically not allowed not to have a critical care ultrasound examination in certain indications in ICU. One of the solid indications is to insert every central line under guidance of ultrasound. And in the coming near future, everybody is going to put in the legal issues inside the ICU for those hemodynamically unstable or respiratory failure patients. They should at any given time, especially immediately upon admission, critical care ultrasonographic, holistic, whole body examination by ultrasound machine. It's not luxurious, ladies and gentlemen. It's mandatory. And we have to come to this culture and believe, because we still hear from the senior people, especially from the senior people, that why I have to go and learn something while I reach this age. No, everybody has to learn. Everybody has to learn, especially if it is like the big societies again say that the basic level of echocardiography, for example, and general critical care ultrasound should be required part of training of every ICU physician. Not only the basic that everybody has to know, but there are indications for subgroup in every unit to have advanced level of critical care ultrasonography. Expert can be found in every region that the reference for critical care ultrasonography. Critical care environment and culture has to have their own system and their own privileges of training, educating, and having their people learn critical care ultrasonography. And again, this is by all recommendations, and we don't have exceptions. Canadian Society of Critical Care Medicine, New Zealand, Australian, American, European, Saudi Society of Critical Care Medicine, and I'm sure Egyptian Society or Emirates Society, everybody is putting among the curriculum that their people has to learn and has to practice critical care ultrasonography. No doubt on that. Look at the Canadian, what they said very clearly, that every unit, regardless of its size, don't tell me that my unit is a small unit, academic or non-academic, teaching or non-teaching, because it's a part of the care, safe care in ICU, safe care in emergency, safe care in every acute medicine, to have critical care ultrasonography unit, machine in your unit. And it's a responsibility of the hospital administration and departmental administration to support having both the machine and the necessary training for all staff. Responsibility of the program directors and hospital directors and IC directors to be sure that their unit is taking care of critical care ultrasonography very well. As I mentioned, everybody is recommending that. Everybody nowadays in critical care, the culture is increasing toward having the advances, majority of the advances in critical care ultrasonography in general, particularly again and again, in hemodynamically unstable or cardiac unstable patients in ICU, they might require, in good percentage of cases, TEE examination. And transesophageal exam in critical care setting has to be done by critical care physicians, because it's very difficult to convince sometimes our colleague from cardiology to do a study while they are not in the same field. They are not in the same environment. They are totally different. They are not frontliners. You are the frontliner. And you have to know now, and now means now, why my patient is shocked. And if you have the transthoracic echo difficult to be done, then there was no way to go except with transesophageal echo. And there are a lot of indications for that. In general, critical care ultrasonography entails critical care echo and general critical care ultrasound. Under the critical care echo, there is transthoracic echo, TTE, and transesophageal echo. And I'm insisting to show this, that part of the critical care echo everywhere, even if you go for a certificate or or any organization that gives certificates, they're going to request you to have TEE. Under general critical care ultrasonography, there is lung, and there is a huge interest in lung ultrasound in acutely ill patients. fast and kidney neurocritical care ultrasound. By bedside machine, you can monitor your critically ill, neurocritically ill patients. Vascular and DVT. This is the general. Let's go through this journey now. The critical care echo is very essential in any hemodynamically unstable patients. One of the clear messages that I want to deliver tonight, and I'm insisting everywhere where I go, on that no hemodynamically unstable patient without critical care echo exam. And this is what everybody expert in this field is recommending. Not the field of critical care ultrasonography alone, but in any hemodynamic expertise field, they are insisting that the hemodynamically unstable patient should receive critical care echo examination, at least for initial evaluation, if not for follow-up evaluation and seeing the effect of interventions. But there are some myths around about the critical care echoes. There were a lot of myths before. We heard some of them in real life, like why critical care physicians should bother about doing echo while I have cardiologists in the hospital and I have echo technician in the hospital. But they are not living in the same environment. They are not beside the patient day and night, 24 hours, 7. Sometimes you request echo to be done at the middle of the night, and then the cardiologist may answer you that we can do the echo tomorrow morning. Tomorrow morning, after a couple of hours, while you can just put the probe and you can see with your eyes and you know exactly the morphology and physiology of cardiovascular system in a very simple way in no time. One of the methods that it has to be a comprehensive exam like what the cardiologists are doing. No, at all. In critical care echo, what you need to answer are 4 questions in any hemodynamically unstable patients. Like what's the fluid status? How's the RV? How's the IVC? Like what's the contractility of the left ventricle? And how is the RV? Is it dilated with evidence that there is obstruction in front of the RV, obstructive shock? Or and the 4th question is, I'm dealing with life-threatening pericardial effusion that tamponading this heart? It's very simple. It can be answered by 2 or 3 views in no time, 3-4 minutes. You come up with the head up and you answer the questions. Yes, there's pericardial effusion, it has to be drained. This IVC is small, I need to give fluid. This left ventricle is very badly contracting, and what do I need to give the biotamin, and that's it. Another myth, which is very common among the practitioners in critical care, is the other modalities of hemodynamics are better than echo. This is totally wrong. The other modalities are helpful. Pico technology, Vigilio, pulsion, arterial line, whatever it is. But this should not be a replacement for echo examination, bedside echo examination of your patient's heart. Let me give you examples of cardiovascular instability that without echo wouldn't be at all diagnosed, real life cases. This patient was 65-year-old in the floor, was found to be febrile, leukocytotic, positive for ESBL E. coli infection. PCT is positive. Everything was toward that this is pure septic shock. And we treated, the team was treating this patient with antibiotics, vasopressors, and that's it. When we did the examination, the critical care examination, we found clearly that the mitral valve had a very big unmissable mass, which was found to be vegetation. And this patient was having moderate to severe mitral regurgitation. And this patient had an element of cardiogenic shock. All indications that directed totally this patient for cardiac surgery, not for treatment of simple septic shock due to TI. And without echo, you wouldn't at all diagnose this. Look at this lady who presented with severe shock with very high lactate, 100 lactate. And then everybody was treating her with fluid, and they're giving her dobutamine, and they were giving her empirically dobutamine and levofed or norepinephrine. If you look at the apex here, you're gonna see that it's ballooning. And this is typical for Takotsubo syndrome. In treating Takotsubo syndrome, you should not attempt to give dobutamine, because dobutamine is gonna increase the left ventricle outlet tract obstruction, because the apex is not working, but the base is overdynamic or hyperdynamic. So with dobutamine, you're gonna increase the base contractility, and this will cause more and more LVOT obstruction. Without echo, how would you know that this is Takotsubo syndrome? You're gonna follow the history and examination. A lady who present with the lactate very high, clinical sign and symptom of shock, and then you hit the history and you might find direction of septic shock or cardiogenic shock, and then you treat blindly. This is totally wrong. Here, when we wean dobutamine and we off it, we give some fluid, we reduced norepinephrine to the minimum. Patient responded immediately, and then we could manage. In every septic shock patients, this is very young patient who presented to us with everything supportive of septic shock. Then he was on levofed 30 mics per minute. This is the echo. See, is this left ventricle in this young gentleman is fitting with hyperdynamic circulation? At all. This is cardiomyopathic patient, diffuse global cardiomyopathy. This is what we know, that septic cardiomyopathy. Treatment here should not be with norepinephrine, should not be with vasopressors. It has to be treating the underlying sepsis, and then the heart needs support with inotropes and vasodilators. And without echo, you wouldn't at all imagine that this young gentleman with this shock, with this history that is toward septic shock, pure. And I bet you now, if I ask you honestly to tell me how many cases you are treating as septic shock and very straightforward septic shock, and then you notice that they are not responding well. And some people, we used to do this before. When we see septic shock patients, they are not responding well, we start to use inotropes, dobutamine, blindly. And then we start to see that urine improved, lactate improves. And we say that, and there was some research on that dobutamine is good for septic shock. Why? This is because up to 30% of cases might reach up to 50% of septic shock patients. They present with cardiomyopathy, septic cardiomyopathy. This is very, very high percentage. Up to 50% of your patients might be with septic cardiomyopathy. You, without echo, you might miss the obstructive shock, especially in old age patients, long history of hospitalization and bedridden, like this lady who presented to me after a night trial with my colleague to treat her as a septic shock. And they were giving her up to 70 mic of norepinephrine with no response. Once I put the probe on the apex, I'm very dilated if you look at here, and the left ventricle is very small, and the pressure across the tricuspid valve was 21 plus the CVP is around 40 millimeter of mercury, a little bit high pulmonary artery pressure. This was found to have also in her big femoral vein, a big thrombus sitting there. So a thrombus in the common femoral vein, acute dilation of the RV with pulmonary artery hypertension, nothing. And a shock patient, nothing except that this lady has obstructive shock due to pulmonary embolism. With 3-4 views, we could diagnose her very clearly. And then this was a real life case, giving her thrombolysis resulted in, after 3 hours, complete cessation or stoppage of norepinephrine. Look at this patient who presented with shock overnight also, requiring a huge mega dose of norepinephrine. When we rounded on him, we found this huge pericardial effusion. And the treating physician was treating as septic shock. I'm sure if he put the probe in that subcostal area or apex, he would discover immediately without any difficulty that this patient has a fluid around the heart. And this is the tamponading effect. And look at here, this is the tube drainage. We drained this pericardial effusion and immediately it was like a hero. It was like a magic action that everything went down totally to baseline and patient completely became normal. Fluid is a very common practice in ICU and in acute medicine. Giving fluid unnecessarily was found by big body of literature that was harmful. Why? Because only 50% of critically ill patients are fluid responsive, while another 50% of critically ill patients, they do not fluid. They don't have to receive fluid. And it was found to be harmful because the more fluid balance, the more harm to kidneys, to liver, to spleen, to lung, and to everything. Mortality increases with positive balance. And Finn's trial, which is a very nice, big, very, very big number of patients and very big number of ICUs everywhere. They tested what was the common indication to give fluid in ICU patients. What they found is hypotension. And imagine if every time you have hypotension in your patients, you give IV fluid. How many boluses you're gonna give per day? 5 boluses, 6 boluses, 10 boluses? Maybe sometimes in about 50% of cases without need. And what you're gonna gain is that you give unnecessarily IV fluid, while you can answer the question very simply with ultrasound, if this patient is gonna require and benefit of IV fluid or not. Look at what they relied on to decide to give fluid. This was published recently, 2015, less than 5 years back. People, they are still in a famous institutions, big institutions. They are still using the CVP with a lot of hazards of relying on central venous pressure to decide for fluid, because there are a lot of factors that might make the CVP high or low. So more than 25% of people shared in this Finnish trial, they used CVP, the most common indicator to give fluid. Look at the echo. Only 2% relied on echo parameters to give IV fluid. So the culture are still very lacking. People are still underestimating critical care echocardiography to decide for many things. People are still working with critically ill patients or acutely ill patients and everywhere in Europe and in America. And majority of ICU physicians, 60%, as this trial is showing, 60% of ICU physicians, they don't know the hemodynamic parameters, the dynamic parameters that they have to rely on before they decide for fluid. And there is no excuse again. There is no excuse to know that simply when you see IVC like this, you give fluid. While you see IVC like this, you should not give fluid. Very simple, when you see lung like this, with this B lines, extensive B lines, this is wet lung. With this IVC, you would give fluid blindly here. Well, it's totally different when the lung is dry, like in here. So very simple, ladies and gentlemen. And then there are a lot of advances and potentials, smart fluid management solutions in the new technology of ultrasounds. You can rely, like in here in Mendre, you can use your machine automatically just to show the IVC, and you choose the smart fluid management solution. The machine will calculate for you the distensibility index, the collapsibility index of the IVC, whatever you are in spontaneous mode, or you are in controlled mechanical ventilation. You just tell the machine will give you numbers without calculating, without multiplying, without subtracting. VTI variation, the smart machines can tell you everything. So the technology is very advancing. We should not stay in the same position. We have to move as people are moving everywhere in the world. And the machines, the manufacturers are moving also. We need support from the physicians to bear in mind, again, that critical care ultrasonography should not be an optional. It has to be a must in every acutely ill patient. The algorithms that are driven from the critical care ultrasonography is far away, was found by literature to be better than other algorithms driven by the other modalities, physical examination, history, the hemodynamic Swan-Ganz or the semi-invasive hemodynamic modalities. Critical care echocardiography can give you the answer: hypovolemia, cardiogenic, dilated, obstructive, fluid, not fluid, precardial not precardial pneumothorax. Everything can be answered in a simple protocolized care, in a simple way, in no time, and you know what you are dealing with and what you have to do and to give to your patient. As I mentioned before, the advances has to be respected, and we have to be ready to cope with these advances. One of the well-known advances is that every ICU, look at this statement in this literature review, narrative review, just published recently, 2019, by a group of very well-known names from everywhere in the world, from Australia, from France, from America, from everywhere. They said every ICU should have its own TEE probe, transesophageal echo probe. And if you are still, and you are responsible about your ICU, if you're the head of the department or program director, and you're still not convinced, please revise everything, because you are lacking a lot of support, and you are putting your staff, your junior at risk, not only not to learn, but also to be medico-legally affected maybe later on. We have to bear in mind that 30% of ICU patients, acutely ill patients, they have no transthoracic echo views because of obesity, because of high PEEP, because of positive pressure ventilation, because of whatever constraints of TTE. And then the solution here has to be TEE. Let me give you an example of this patient who had a 10 minutes of CPR, 80-year-old, bedridden, had a multiple stroke, had a UTI, MRSA sputum, 37,000 WBCs, arrested and post-cardiac arrest. He's shocked. And then when we tried to examine him with echo, this is what we found. There is no view. This is the parasternal long axis view, nothing to be seen. This is short axis view, nothing. He had a big tube in the subcostal area. The only view that we got is this subcostal view. Look at it. The RV is collapsing. And there is something outside of the RV here, which might be pericardial fat and some fluid here also. The question was, this patient might have effusion and might have a pericardial tamponade. What to do now? We don't have, as a basic rule, you should not rely on one view to decide for any intervention. You have to have a convincing views that I see this abnormality here in the subcostal, I see it in the apical view, I see it in the parasternal long axis. More than one view you have to rely on. Then we cannot see anything. What to do now? Post-cardiac. This is what we saw. This is the liver. There is a huge effusion on the right lung here. And this is the fast, this is the liver, this is the kidney, and here you see effusion also, or ascites. So this patient has fluid somewhere else. So what we saw in the subcostal was probably pericardial effusion. Very shocked, post-cardiac arrest, he might have arrest again. So we have to tap this, but we cannot rely on this. We have to do transesophageal echo. Look at this. When we did the transesophageal echo, there is no single drop of pericardial effusion. See this? This is the right ventricle here, and this is the pericardium. Nothing is in the pericardium circumferentially. This is the left ventricle. This is the left atrium. This is the right atrium. This is the right ventricle. But look at the left ventricle here. It's very hypokinetic. So this patient has a myocardial infarction, and it's a cardiogenic shock. There was no, for sure, there was no pericardial effusion, and without transesophageal echo, this was not at all possible. The common scenarios on lung or respiratory failure. Common indication to admit to ICU is respiratory and cardiovascular failure. Common indication for the cardiovascular system to fail, common reason is respiratory failure. Common reason for the respiratory system to fail is cardiovascular failure. And these two are the common indications to admit to ICU. The lung, the critical care ultrasonography plays a major role to diagnose up to more than 90% of the causes for acute respiratory failure. One of the famous, very famous protocols for this is Blue Protocol by Lanstein. In a few minutes, in a simple lung exams, you can diagnose for the reason for respiratory failure, one of these common reasons for respiratory failure: pulmonary edema, pulmonary embolism, COPD, pneumonia, pneumothorax. In no time, in a simple way, sliding positive, not positive. B lines, no B lines. A lines, no A lines. DVT study. A matter of 5 to 10 minutes. You can diagnose 80 to 90% with 100 up to 100% accuracy of the reason for acute respiratory failure. This lady presented to us in ICU in a severe life-threatening asthma, history of bronchial asthma. She's 70-year-old and was found to have now, again, wheezes audible from outside the room. And the people working in ICU, the staff, noticed that once this lady becomes tachycardic for whatever reason, she becomes very wheezy. And what they do is to put her on BiPAP, give her more bronchodilators, give her sedation, heart rate increases more with bronchodilators, beta agonist, patient become more and more sick. When we did the echo, as you saw here from this view, that the posterior leaflet, when the valve is closing, look at this M mode, the mitral valve leaflets closes the left ventricle outlet tract with every diastole, with every systole, sorry. When the aortic valve is opened, then the mitral valve will overlap to close the left ventricle outlet tract, what we call it SAM. And this is the reason for this lady to go into life-threatening asthma every time she becomes tachycardic. And what was worsening her is the beta agonist. Without echo, you wouldn't at all diagnose this lady, who is known for several years and admitted before to ICU with life-threatening asthma. But this time, she came with asthmatic attack, and it was actually bronchial but cardiac asthma attack because of LVOT obstruction due to SAM. Without echo, you wouldn't at all diagnose this. Reason to think of that you respected the history and you put in mind that every patient who is presenting with respiratory sign and symptom or respiratory failure has to have echo examination. Look at the septum here. There is hypertrophy of the base of the very down segment of the septum. This is sigmoid septum. And the mitral valve with tachycardia will, during the diastole, this has to be seen with M mode. Like in here, you see this is the mitral valve leaflet, and this is the tract during the systole. It's closed by the mitral valve. So there is no blood goes to the aorta, but it goes backward to the mitral, to the atrium, and then to pulmonary veins and causes pulmonary edema. In acute respiratory distress syndrome or ARDS, what everybody knows in ICU, that one of the criteria to diagnose ARDS is to have chest imaging to tell you that there is bilateral lung infiltrates with acute hypoxia, BF ratio less than 300, acute event, bilateral lung infiltrates. Diagnosed by what? By chest modalities of imaging. What Berlin definition decided is, look at here, chest radiograph or computed tomography. So there is no ultrasound in Berlin definition, which was in 2012. Evidence showed that there is a huge time lag between the X-ray finding at chest X-ray plane and the lung ultrasound to discover or diagnose pneumonia early. There is a very big time lag. Look at this patient, young, fever, cough, high white cell count, high PCT, procalcitonin, septic shock. Look at the BF ratio, was consistent with severe ARDS. X-ray looks totally normal. People, they have to think if they rely on a chest X-ray to diagnose ARDS here, that there is no bilateral lung infiltrates. Either you go with CT to see, if you're still considering pneumonia, you have to go with the CT. Patient is unstable, on high flow oxygen, intubated, high PEEP. What to do? The X-ray before intubation was looking totally normal. But look at the lung ultrasound here. Very congested. Look at the B lines here. Look at the effusion here. Look at the consolidation and collapse here. The X-ray doesn't show them at all. This is upon admission. This patient has bilateral lung infiltrates, consolidation, bilateral collapse, bilateral effusion, bilateral very wet lung. Everything was consistent with pulmonary edema. Another views, everywhere you see fluid, very corrugated, thickened, abnormal pleura, B lines, underlying consolidation and collapse. So the X-ray is lacking. Lacking is the sensitivity and specificity. That's why we started to see evidence. And this is Kigali modification of Berlin definition. They inserted the chest radiograph or ultrasound to be used to document that patient has or doesn't have pneumonia or bilateral lung infiltrates. Everybody is changing toward using critical care ultrasonography. In every critically ill ARDS patients, up to 50% of patients, they develop acute right ventricular failure. And without echo, you wouldn't at all be able to diagnose this type of patients. This is ARDS patient. This is the view before we increase the PEEP, and this is the view after we increase the PEEP. If you blindly increase the PEEP and you leave the right ventricle to suffer by dilation and increase in the pulmonary artery pressure, you're going to increase the risk of mortality, and hypoxia will not improve. And the message that everybody knows nowadays, and since a long time, that every ERDS patient has to have an echo examination before and after changing the PEEP. Why? Because if you change the PEEP and you causes better oxygenation, but the RV is suffering, this is not a right decision. You have to go back to the minimum permitted saturation that save the RV. RV is a priority like hypoxia, the management of hypoxia priority. Oxygen is good for everything, but the RV is the main chamber for everything in the tissue metabolism and oxygen delivery. We have to respect this. And without echo, you wouldn't be at all able to diagnose acute cor pulmonale, which is common in ERDS patients. And that's why we see evidence recommending that if you have pneumonia as a reason for ERDS, driving pressure more than 18, BF ratio less than 150, BCO2 is more than 48, the risk of developing acute cor pulmonale, the more you go more than 2, the more risk will be there. And if the risk from this score reach more than 2, routine echo examination for every ARDS patient is mandatory. This is medical legality, ladies and gentlemen. We should not leave the RV to suffer in any ARDS patients while we are happy that we achieved good oxygenation. You have to put the puzzles together. When you try to improve the oxygenation, do not forget the RV, because it's very important. Lung ultrasound, as a part of critical care ultrasonography, is equal to CT with a specificity and sensitivity more than 90%, reaches 100% like the CT in diagnosing pleural effusion, consolidation, pneumothorax, interstitial lung syndrome, 100% like the gold standard. So you might send your patient for CTE to see if they have pneumothorax or not. Well, this ultrasound bedside can do this for you in 2 minutes without the risk of CT. There are a lot of promises about the lung ultrasound in early diagnosis of VAP and tailoring the antibiotic management, an oxygenation assessment in prone position, in ERDS to assess the aeration and response to interventions and to see if your patient is de-recruiting or not, a lot of things. And also during the weaning process which constitute around 40% of our daily work in ICU. There is a bivotal rule for critical care ultrasonography in weaning patients to see the lung, heart, and diaphragm. And you should not attempt to wean or liberate from mechanical ventilation without evidence that these three cornerstones are fine to start the process and journey of weaning. That the lung is not wet, not de-recruited, and the heart is strongly or powerfully or reasonably contracting, and the diaphragm is well to take care of the inspiration when you take the tube out. Without ultrasound, the evidence is showing that the sensitivity to predict weaning success when it came to compare the lung, the diaphragmatic excursion and thickness fraction to the RSBI, the sensitivity was more than 80% and specificity reached more than 90%. And it was far better than the RSBI. FAST, which is the focused assessment, sonographic assessment of any trauma patient, is not only for trauma. People, they believe that this is only for trauma. It's for anybody who is hemodynamically unstable, and you believe is that the source is inside the abdomen. This is lady with polycystic ovary. We were consulted because she became shocked now. And they said this is hypersensitivity, reaction, and this is not hypovolemic. It is hypovolemic, but not bleeding inside the abdomen. We said it might be bleeding. So let's examine her abdomen bedside by this ultrasound. What we see here in this bottom left side, that this is the liver, this is the kidney, this is the Morrison pouch, and there is fluid here, hypoechoic shadow. This is fluid. Fine. This might be a transit fluid, might be fluid transit, not blood. But look at here. What we notice is that there was a clot inside the Morrison pouch, moving freely inside the peritoneum here. We said, no, this patient has bleeding inside the abdomen. There were some argument for almost 2 or 3 hours. Patient was not responding. Hemoglobin was dropping. And we said, our ultrasound tells that this patient has a clot inside the abdomen. We pushed the surgeon to open this patient's abdomen. What they found, 4 or 5 liters of blood inside her abdomen. And this decision, they found a spurter, big artery bleeder. They controlled the bleeding and patient was saved. And the decision was taken based on bedside in 1 minute examination. I have another case of dissecting abdominal aorta who was transferred to us with the same scenario for elective surgery after 2 days. He started to be a little bit hypotensive. Treating team said, just consult ICU. When I went there, I found the same finding, a clot inside the abdomen. Clot means that there is active bleeding. There was no time to take this patient to CT. He was taken to OR. And what the surgeon found is rupture of the aorta. And he said, literally, if we waited for a few minutes, this patient would die. It can be life-saving, ladies and gentlemen. It can be life-saving for you to bear in mind that inserting line, which is daily practices in ICU and acute care, if it's done without guidance by ultrasound, it can be dramatically jeopardizing the care and causes a lot of damage. And in spite of this evidence on how important to guide your central line with ultrasound machine, it's among 11 safety guideline protocols everywhere in the world. This literature in French ICUs They surveyed the doctors working in ICU. It was published recently, 3 years back or 4. 65% only used ultrasound guidance in central line insertion. And 35% of doctors found it unnecessary. And we hear this from the anesthesiologists, good senior gentlemen, because they have very good skills in putting lines. And they have the trust and overconfidence that we do it blindly. One of them told me, I can put the central line while I'm closing my eyes. I believe in that. But do you know that up to 2% of patients, they have no internal jugular line? There's no internal jugular on this side. Or the internal jugular anatomic relation to the common carotid is reversed. Some people, they don't know this. This is anatomical fact, by the way, was found in the literature. Just go, you see a lot of evidence on that. And let me ask you honestly, how many times did you try to put central line, but you couldn't? A lot of punctures. You fill the artery, you go lateral to the artery, 1 centimeter lateral to the carotid artery pulsation. You go typically as you used to do in hundreds, if not thousands of cases, and there is no blood flow back. Without ultrasound, you wouldn't know. Not only that, but also imagine if you are putting a central line to this internal jugular. Look at inside the internal jugular here, there's a big thrombus. Look at the longitudinal axis of the internal jugular here. The thrombus is closing totally the internal jugular. There is no blood intake here, the color. So if you attempt to go through this thrombus, what you're gonna do? The wire wouldn't go, number 1. Number 2, you might dislodge this thrombus. And so the advantage of having the examination before attempting to do the central line insertion is, number 1, I wouldn't try because I saw the thrombus. Number 2, I saved this patient cardiac arrest due to pulmonary embolism. And let me ask you to review your memory backward. How many times you might have it incidentally or coincidentally that during the insertion of a central line patient had a cardiac arrest? I hear these occasions. I heard a scenario of inserting line, immediately patient had a cardiac arrest. And we attribute this to pneumothorax. Might be to pneumothorax or might be to something else, like dislodging a fresh thrombus in internal jugular, especially in chronic patients in ICU or in the ward who are at risk of thrombus formation. Sensitivity, ladies and gentlemen, of ultrasound to diagnose DVT everywhere in the body is 95%, and specificity is 93%. So false negative and false positive results are very minimal. Bedside in no time, without asking radiology to come, or you move patients to radiology suite without convincing people in the radiology department to send you somebody to image and to interpret the images in unstable patients. You can learn this. It's very easy. It's doable. And we did, as several body else, several societies, several researchers did better than us even. But this is a study we published several years back about the advantages of having the dynamic ultrasonographic guided central line insertion compared to blind technique, and was found to be very, very much better. In neuro ICU, ICP monitoring was found to be valuable tool you can rely on with good reliability and good sensitivity and specificity. Optic nerve sheath diameter and transcranial Doppler. Optic nerve sheath diameter, if it's more than 0.6, was found to be sensitive more than or around 80% to tell you that the ICP is high. Why? Because the optic nerve is in continuity with the subarachnoid space, and the sheath surrounding the optic nerve is in continuity with the sheath around the brain. So if anything causes the brain ICP, intracranial pressure, to increase, will affect on everything, including the sheath around the optic nerve. It dilates. And this is very simple test that we teach people to do it in our hands-on courses. And it's very easy and very reliable and more than 80% sensitive and more than 80% up to 90% specific to predict ICP pressure. Transcranial Doppler is very, very useful in critically ill patients. Again, to detect ICP increase, to diagnose brain death. It's one of the confirmatory tests to diagnose brain death in critically ill patients. And sometimes it's impossible to send patients to 4-vessel angio, or your EEG machine is not working, like the situation in some hospitals. Then in the everywhere brain death 4, you're gonna see that the transcranial Doppler showing no flow is one of the confirmatory tests for brain death. And again, is it something that can we learn and apply? Very easy to learn and apply. We published very recently about the use of optic nerve sheath diameter as a good screening tool. We published this with our group of researchers in my hospital very recently in Irish Journal of Medical Science. What we did is we compared the optic nerve sheath diameter by ultrasound to the CT and to the invasive tools, ICP monitoring by invasive maneuvers. And we found that it was with a sensitivity very near to the invasive monitoring tools. So what I want to say that learning critical care ultrasonography is something not impossible. No, it's very easy. Resources are there everywhere to learn. Internet, YouTubes, groups, read, watch videos, join us on our seminars and webinars and virtual activities that we are doing. We did up to now 10 courses in the Eastern region, everywhere. Not only in Eastern region, but we went to Bahrain, Dubai, Jeddah, Cairo, everywhere. And not only with our group, which is known here in Eastern region in Saudi Arabia, but also with American Society of Intensive Care, with WIMFocus, with local societies. Everybody now can have the access to learn and to practice critical care ultrasonography. In the time of the curfews and the restrictions because of the COVID, we thought of something that can be online. Our target, ladies and gentlemen, is to reach you everywhere, is to find you everywhere with tools that we can share together, PowerPoint, videos, active interactions. And we're starting with this chest ultrasonography course, which we're gonna start on July 3. This will be virtual. We're gonna bring evidence of lung ultrasonography. How can it be very simple to learn, believe me. Just know the basic, catch your probe. And I'm sure that most of the ICUs and ERs and ORs, they have their own machines. And what is left for you is to know how to use these machines. And again, it's something very easy, very accessible. This is how can you reach us. And if you are interested to register in this coming virtual course, you are more than welcome from everywhere in the world. We are happy to answer your questions. Just reach me on WhatsApp if you wish, or my email, or my pages on Facebook, or in LinkedIn. I'm gonna be more than happy to answer any question at any given time. And even I know other people who are better than me to answer you and to help you in sending videos through WhatsApp, share them with us in the WhatsApp group or on the Facebook, and we can comment on each other. We learn from each other. There is no excuse not to learn critical care ultrasonography. And by here, I'm very thankful to all of you, and thankful also for the Mindray company. Microphone is for you, Mr. Muhammad.
Thank you, Dr. Ashraf, for your great presentation. Next, it will be the Q&A section. Before that, if you are interested in Mindray ultrasound solutions, please find my contact in the chat box. So any question, please? Yeah, here we have some question in the chat box. Yes. The first, what is the best fluid responsive assessment, doctor?
Yeah, great. If you have ventilated patients, it's totally different than when you have a spontaneously breathing patient. And spontaneously breathing patients, you can rely on eyeballing assessment of the IVC and RV. If the IVC is smaller than 1 centimeter and RV looks to you small, straightforward, go ahead and give fluid. Here, this can be supportive to the history and examination. If the history is consistent with hypovolemia and you see the IVC is collapsing significantly and the size is less than 1 centimeter, straight away, give fluid. By the way, if the history and clinical examination is consistent with hypovolemia, this might be deceiving. So again, better to have evaluation of the IVC and RV. This is number one. Number two, if your patient is mechanically ventilated and controlled ventilator that don't have spontaneous breathing, the best way is to go with distensibility index of the IVC. So you put the probe on the IVC and you see how much the maximum diameter minus the minimum diameter over the minimum diameter divided by, multiplied by 100. If this is more than 20% indicative of fluid responsive. If you have TEE, you can go with superior vena cava collapsibility index, more than 36%. Collapsibility is different than the distensibility. Something will collapse from the maximum and something will distend from the minimum. So distensibility, you divide by the minimum. So the big size, the big diameter, minus the minimum diameter, the smaller diameter, divided by the smaller diameter, this is the distensibility. Collapsibility is the reverse. The big diameter minus the small diameter divided by the big diameter, times 100. In mechanically ventilated patients, but they have a spontaneous breathing, you can go with collapsibility index. And RV should not be forgotten. If the RV is dilated, should not attempt to give fluid, especially if you see paradoxical motion of the septum. If the septum is moving toward the left ventricle with systole, should not give IV, absolute contraindication for IV fluid. Yes, I answered. Of course, you should not also forget to comment on the lung. As I showed you, the lung has to be wet, has not to be wet. Wet lung does not accommodate more fluid. Or if the patient is looking for you as a fluid responsive, but the lung is wet, sometimes in ERDS, better to go with colloid, not with crystalloid. Because 70% of the crystalloid will leave the circulation to interstitium immediately, where the colloid remain in the circulation and 75% remains in the circulation for longer period of time. That's why. Thank you.
Thank you, doctor. Is there any superiority of CT chest scanning over ultrasound chest scanning in diagnosis?
Great question. Evidence is showing with no hesitance that CT ultrasound, lung ultrasound, is equal to CT in pleural effusion, pneumothorax, consolidation, interstitial lung syndromes. The superiority of the CT over the lung ultrasound is on the mass assessment and to see the mediastinum. If you have mass or suspicion of mass, to see the size, the surrounding. If you have a deep abscess formation, CT is the gold standard and ultrasound cannot help. But otherwise, in the common indications of radiologic indication for chest, CT, lung ultrasound is equal to CT. Equal to CT. Again, in another rephrased statement, lung ultrasound is not inferior to CT. By evidence, this is not a sensation or just feeling because I love, because I'm biased. No. Evidence is showing that lung ultrasound. But let me tell you something. Lung ultrasound is superior to CT in two things. Number one, in pleural effusion, because in pleural effusion, you can see and quantify with more accuracy the amount of fluid, number one. Number two, you can identify what type of pleural effusion you are dealing with when you do the examination with ultrasound lung. It's gonna tell you if this effusion is complicated or not. CT will not tell you this because you see live the lung windows, how the fluid looks like, and you can see debris inside the fluid. I'm gonna show you a lot of videos. If you're interested, join us in this course. I'm gonna show a lot of videos, real life cases of how the effusion looked in the lung ultrasound. Very simple, very, very simple.
Thank you, Dr. Ashraf.
I forgot to mention also, Malish, sorry, Mohammed. Another great advantage of lung ultrasound compared to CT in cardiogenic and non-cardiogenic pulmonary edema. CT wouldn't tell you at all. CT will tell you that the interstitium is wet. There is pulmonary edema. Cardiogenic, non-cardiogenic doesn't tell. But with lung ultrasound, and there is a presentation complete, maybe 1 hour in our course about this, how the lung ultrasound will look like in ERDS in non-cardiogenic pulmonary edema compared to cardiogenic pulmonary edema. How the pleura looks like, how the subpleural looks like in non-cardiogenic, how the B-line looks like in non-cardiogenic, how the B-line looks like in cardiogenic. So a huge advantage. Okay, go ahead, Mohammed.
Okay, how to estimate best beep by ultrasound? How to estimate
Great.
best beep by ultrasound?
Two important points you have to put in mind in answering this question. PEEP is to recruit the lung. You apply the PEEP to recruit the lung. But the PEEP has a major drawback on the right ventricle. So before you apply increasing the PEEP, go to the basis of the lung and see how much collapse is there. There is what we call it lung score. And then in the basis toward the PLAPS area and the mid-axillary line, how much collapse is there, increase the PEEP bilaterally. You see the lung bilaterally. And then see again after half an hour to 1 hour, is this PEEP resulted in recruitment of the segments? So I don't see now collapse. I started to see aeration. So this area is now showing no consolidation or collapse, or started to see B lines or A lines. Well and good. Go to the right ventricle before you increase the PEEP. How was the size of the RV? At the same time, how's the blood pressure? When you increase the PEEP and you saw the recruitment is done well, look at the right ventricle again and see, does the right ventricle suffer now? So it starts to dilate, stop increasing the PEEP, reduce the PEEP again to come back with the RV to its normal size. This should not be forgotten. So when you apply the PEEP, you can use the ultrasound before you increase the PEEP to see how much collapse do you have bilaterally. Increase your PEEP, baseline RV, increase the PEEP, see the lung again after 1 hour, done the job in the lung, look at the heart. The job is maintained still, the RV can tolerate, well and good. If not, tolerate hypoxia, but do not tolerate RV failure, because what you need is saturation more than 88%, not more. People, they like to see saturation 100%, and that's why they go very high with PEEP. There is in the literature evidence, argument about PEEP is high PEEP better than low PEEP. This is still debatable. One of the things that makes it debatable is the effect of the PEEP on RV, because you're gonna, when you're gonna win nothing. If you causes improvement in oxygenation, but you causes failure of RV. And that's why there is in the literature good reviews stated or mentioned, highlighted, that RV knows which beep is better. The RV knows, not the lung. So the best beep is the beep that tolerate and respect, the RV, anatomy and physiology. Thank you.
Doctor, what about the fluid therapy in AKI, not shocked? Is there any role of ultrasound in IVC measurement? Have role here even in the hemodynamically stable patient?
Very good question. Again, it applies the same principle. If you believe that the acute kidney injury is due to pre-renal causes, then apply the same principle. Evidence of hypovolemia, give fluid. But there is another very important point here also. When we talk about critical care ultrasonography, what makes critical care ultrasonography very special and very unique is that it is a holistic, whole body ultrasound. So when you have acute kidney injury, you determine that this is pre-renal, the kidney is hypoperfused, you can see hypoperfusion evidenced by abdominal ultrasound. Use the Doppler and color, and then you can see the PI of the kidney. And then you can give the fluid and see the perfusion of the kidney, improved or not. And again, it's a holistic. So when you decide to go with critical care ultrasonography, to give fluid or not to give fluid for whatever organ, there is a protocol for everything.
Thank you, doctor. In case of sepsis, how sure are you the cardiomyopathy is due to the septic cardiomyopathy instead of chronic heart failure due to the poor EF, ejection fraction, hypokinesia?
Very good question. First of all, you have to put in mind that every septic patient is at risk of cardiomyopathy due to sepsis. Septic cardiomyopathy is common. 30 to 50% of patients, they develop cardiomyopathy. If the baseline that this patient is non-cardiomyopathic, the risk is higher. So any patient who is cardiomyopathic in the septic context should be dealt with as a septic cardiomyopathy. Number one, that's why we're saying that any patient who is admitted to ICU deserves to have critical care echo examination at presentation. If the patient's heart was hyperdynamic, now hypodynamic, there is no other alternative. This is septic cardiomyopathy. If on admission, patient is cardiomyopathic and non-cardiomyopathic, this is something else. But there is no definitive diagnosis or a hallmark of septic cardiomyopathy, except that you see that globally the heart is hypofunctioning in this septic shock patients. That is the clear answer for this.
Thank you, doctor. How much time we should take to see overall the chest by the ultrasound in the era of the pandemic?
Very good question. Thank you very much. First of all, your safety is priority. If things can be answered while you are far from the patient, answer the question while you are far from patient, at least 2 meters. If things are not answered by the routine things, which is X-ray, and here you go better with chest X-ray and the other modalities, don't come closer to COVID-19 patients if you can manage without. But if you have to examine your patient because he or she is hemodynamically unstable now, and the X-ray is not available, then minimize the time of examination to the shortest possible time. You go with 2 site exams in COVID-19 patients, only 2 sites, chest-wise. Go to the anterior chest, mid-clavicular line in the 2nd or 3rd intercostal space. And then go direct to the PLAPS area. PLAPS is the most posterior segment area down to the nipple at 8th or 9th intercostal space toward the posterior axillary eye. Put your probe, the low frequency probe. This will give you a clear answer about consolidation, collapse, and effusion, and B lines. So four questions in one side. The mid-clavicular anterior chest will answer for you the question of pneumothorax and wet lung, presence of A lines, and wet lung, presence of extensive B lines. When you do the examination on the right side, you might repeat the examination if needed on the left side. If you are satisfied with one side, more than enough. But again, in ERDS COVID patients who are unstable, COVID-related cardiomyopathy or myocarditis is common in 30% of patients. And RV failure is common also. Thrombosis can be diagnosed. Pulmonary embolism is not infrequent. It's common in COVID-19 patients. And all these can be answered by echocardiography bedside. 3 sites has to be examined very shortly. Apical 4, short axis parasternal, and subcostal view, not more, and not details. Just put the probe, see the size of the RV, size of the LV, any pericardial effusion, any dilation of RV, and that's it. If you get the answer from one view, get the second view, and that's it. 2 view might be enough. Bottom line, minimize the risk of contacting patients because your safety is priority. Thank you.
Look, if you have a patient with combined septic, ABD, cardiogenic shock, can the ultrasound help for the fluid management and for good diagnosis?
Very good question. Not every cardiogenic shock are not fluid responsive. There are some patients who are cardiogenic shock and fluid responsive. And on the other hand, not every septic shock patients are fluid responsive. So how I would know if my patient who is cardiogenic and septic are still fluid responsive? If you remember with me, the Frank-Starling curve. The Frank-Starling curve, which is the fluid versus cardiac output, or the pressure versus the cardiac output, not the versus the against the cardiac output. The more you increase the fluid, the more you increase the contractility or cardiac output. The more you increase the pressure, the more you increase the cardiac output. In a Frank-Starling curve, the curve, there is a flat portion and a steepening going up curve portion. The more you increase the fluid or the pressure, you see increasing cardiac output, patient is still responsive, till you reach a point at the flattened portion of the Frank-Starling. Here, the more you give fluid, the more the heart will fail and the cardiac output will not increase. What I want to say that in Frank-Starling, some of the cardiogenic shock patients, they have a small room for accommodating small amount of IV fluid. So we have difference here between challenge fluid or bolus fluid. Bolus is 250 to 500. Some people, they say 4 to 7 ml per kg, while the challenge is created for the cardiogenic patients. You challenge the heart with 100 ml. You give 100 ml and see the cardiac output. Let's talk ultrasonography. How can I know if my patient he is cardiogenic or septic cardiogenic, still has a room for IV fluid response? This is by VTI. the velocity time integral. But there are certain requisites, prerequisites, that they have to be controlled mechanically ventilated, should not have any spontaneous breathing. They should be in sinus rhythm. They should be in a good tidal volume, 8 ml to 10 ml per kg. If you have these prerequisites, you can get the 5-chamber view, put the pulsed wave Doppler on, the area of LVOT, you fire it, and you see the VTI during inspiration, VTI during the expiration, take them the variability index, which is the during inspiration minus the expiration divided by the expiration times 100. If more than 12%, patient can accommodate fluid. If your patient is non-cardiac or septic cardiac patient, septic cardiomyopathy, go with a challenge, 100 ml to maximum 200 ml, and see if the VTI will increase, cardiac output increases or not. If the cardiac output increases with this mini challenge, go ahead and give more fluid. There is a very nice, simple, practical, other bedside tests. Number one is the passive leg raising. Patient in ICU mechanically ventilated or not mechanically ventilated, sinus or not sinus rhythm, in a small tidal volume or big tidal volume. Just flatten the head and then raise the legs, not by hands, not manually, but automatically by the bed. What we do, when you flatten the head and you increase the legs upward 45 degrees, then you are as if pushing the fluid from the pelvis, lower extremity and lower abdomen toward the heart. It's equal to 300 ml of blood goes to the right ventricle in less than a minute. If the cardiac output or VTI, stroke volume, if it increases by more than 15%, this patient is fluid responsive. If the cardiac output doesn't increase, then this patient is not responsive. What you're gonna do? If you give bolus IV fluid from outside, you wouldn't be able to retain this fluid again outside. But with changing the position again, legs down, head up, you throw again the blood down to the extremities. And that's why passive leg raising is very beneficial in acutely ill patients or ICU patients. There is what we call it PEEP challenge. If your patient is ventilated, you can increase the PEEP by 5 centimeters suddenly. And you see if the cardiac output decreases significantly, this is indicated that this patient is fluid responsive. If not, there's another third test, which is expiratory hold for 15 seconds. Patient is controlled mechanical ventilation or not controlled. Spontaneous breathing can be also patient on ventilator, but they are not fully controlled. Just to hold the expiration, hold expiratory pause for 15 seconds and see if the cardiac output change or not. If the cardiac output during the exhalation increases while you're holding, this is indicate that this patient's fluid response. That's it. There is a full lecture about this in previous webinar. We touched this.
Thank you, Doctor. This is the last question we have. Having mentioned use of echo in diagnosis of acute corpulonal on acidosis in ventilated patient, do you recommend milrinone?
You are talking about acute cor pulmonale. What's acute cor pulmonale is acute dilation of the right ventricle with increase in pulmonary artery pressure and paradoxical septal dyskinesia. This is the cor pulmonale. So you have a strain on the right ventricle, big strain, pressure strain on the right ventricle. Milrinone dobutamine can be helpful, but there is no strong evidence on that. But it can be tried, like nitric oxide can be tried. Phosphodiesterase inhibitors can be tried. Dobutamine levosimendan, and also milrinol. Yeah, there is, but there is no big evidence to support that. This is for best of my knowledge.
Doctor, we have the last question, sorry. The same question about the combined septic and cardiogenic shock. If the fluid changes was positive, challenges was positive, how much fluid shall I give?
Yeah, you mean if your patient responded to first bolus? When the evidence comes to fluid therapy, we have to respect the fluid therapy as any decision therapy for critical ill patient. It's a decision, it's a drug. You have to have clear indication to give, and if you have a clear indication not to give, you should not give. Sometimes the solution is to remove fluid, not to give fluid. So the question now, if I did the test and I found my patient is fluid responsive, you have to have cardiac output monitoring. When I say you have to have, it indicates that it's better to monitor your patient with cardiac output modality. Cardiac output modalities are either invasive, starting from the Swan-Ganz, and the thermodilution technology, pulsion technology, or Vigilio technology, or non-invasively with echo. Cardiac output monitoring is a must. Before you decide to give, and then you decided to give the first challenge or bolus, the question is, how many boluses do I need? You can still give fluid for any hypotensive. First of all, if your patient is not hypotensive, you should not ask the question, except in very subset of patients, very few indications. The first indication is hypotension. Then I ask myself, should I give fluid or not? So in hypotensive patients who found to be fluid responsive, start with the first bolus, 4 to 7 ml per kg. If they respond to this bolus, you can repeat the boluses. For how many boluses, nobody knows. But there are marks that when you achieve, you have to stop giving fluid. Number one, if the stroke volume or cardiac output or the surrogate of both, which is VTI and easy to measure by transthoracic echo and transesophageal echo. If the VTI doesn't increase more by more than 15%, stop to give fluid, no more fluid. This is number one. Number two, if you started to see B lines on lung, this is the time when the fluid now overfilled the circulation and started to go to the interstitium. Then you have to stop giving IV fluid. So two parameters you follow. The best is to go with cardiac output, but not to forget the lung. Presence of or new presence of B lines on the lung should be respected to stop giving IV fluid. That's it.
Okay, thank you everybody for attendance. Hope you enjoyed your time and hope to see you again. Have a good night. Thank you all.
Thank you very much, Mohammed. Thank you, Mindrey. Thank you for everybody. Thank you very much.